Good morning. Thank you all for coming. My name's Alexis Desir. I'm a senior resident at UT Southwestern, and I will be discussing the affirmation topic. Oh, okay. Sorry. This study was funded by an NIH R01 grant. So just to start, by a show of hands, how many of you have performed a perineal proctectomy? Okay. Keep your hand up if you're in training, and keep your hand up if you've done more than 5. Okay, so as we can see, even in this room, our clinical exposure to this procedure may not be as high as we all think. Perineal proctectomy, as many of us know, is a complex procedure largely due to its distorted and inverted anatomy. And their clinical exposure is lacking, as we can even see in this room, as well as there's lacking current simulators for training. So our lab's ultimate objective is to develop a virtual reality simulator to increase the amount of exposure and practice for this. But to start, you have to start with developing task-specific metrics. What this means is breaking down the procedure into specific tasks and then further breaking that down into specific grading skills. So that way you can eventually give the person who's using the simulator direct objective feedback. The study objective of this was to evaluate the discriminant validity, so can you tell the difference in expertise by these task-specific metrics, and reliability, how consistently can you do this, of these task-specific metrics in comparison to validated global performance ratings. So we had 2 groups of participants with a total of 22, which is normal for a surgical education study. We had 15 novice, which is PGY 1 through 3. We picked this because interns may not have as much exposure in the operating room, and then we don't rotate on it again until 3rd year, of which you only have 1 month, so you may not have as much exposure. And then experts were categorized as PGY 4 through 5 in attendings who would have much more exposure to the colorectal rotation. We asked them to perform the Altemeyer's perineal proctectomy on a simulated rectal prolapse model, and they had 1 hour to complete on this fabricated model seen on the screen using a lifelike biotissue and custom modeled silicone. If you can see that little indentation made with a hemostat is to represent the dentate line. They were also asked to complete a pre and post survey. The camera, as you can see, is set up with this participant here, is set up to only show their hands performing the procedure and nothing else in order to keep the participants de-identified. Video recordings were independently assessed by 2 blinded raters using global ratings such as OSATs. These you might be more familiar with, so things like respect for tissue, flow of operation, bimanual dexterity, etc., and our task-specific metrics. A few of those include initial incision, so did they do their initial incision within 2 centimeters proximal of the dentate line? Was there excessive force on the tissue to the point where they maybe even caused a rectal perforation during the dissection? Did they have full closure of each suture? Did they have filling of the intervening spaces appropriately? These are just a few of the task-specific metrics that we looked at when grading these videos. Our results were positive. We had high inter-rater reliability for both global and task-specific metrics, meaning both graders grading had very similar scores. There's a strong positive correlation between global and task-specific scores. So those that did well globally also did well task-specific, which is very important. And then most importantly, we had significant between-group differences. So in the figures you can see, on the left is the global scores and the right is the task-specific. Novice is in the blue and experts is in the orange. And you can see that the expert grades are higher, hence the box is higher, and the novice were lower. And not only that, but it was significant. So just grading based off of our task-specific metrics by watching the videos, our metrics could determine if the person performing the procedure was a novice or an expert. So along with this was very encouraging data for the development of a virtual reality simulator, and the potential future implications were that if we can implement these task-specific metrics into a virtual reality simulator, we could potentially provide more objective feedback, more exposure, and then maybe even down the line improve surgical outcomes. Our next step is to integrate these into the virtual reality simulator, which since submitting this abstract we have done, and this is what it looks like. So you can see that there's a dentate, well, it's harder to see, but the red squiggle line on the top is a dentate line. There's mesentery in between, there's 2 layers of the bowel, there's all the tools that you would use in a live operation, and this is now we test the participants again on the VR simulator. Thank you so much. Do you have any questions?